Welcome to this BTOG podcast. My name is Tom Newsom-Davis. I'm a medical oncologist at Chelsea and Westminster Hospital in London. I'm also the Vice-Chair of the BTOG Steering Committee.
And I'm Leanne Castle, a respiratory physician at Barts Hospital in London.
This is part of our regular podcast series where we have informal chats with experts in their field and tackle the most important issues that we all face in the diagnosis and treatment of thoracic cancers.
It is important to say that the sponsors of BTOG do not have any role whatsoever in the planning, content or delivery of anything discussed in these podcasts. We would love to hear your questions and comments on things we've discussed in this podcast. Please contact us by emailing us at info@btog.org or tweet us at btog.org.
Hello, everybody, and welcome to this edition of the BTOG podcast. I am by myself today. Leanne sadly is not joining me because it's been recorded during the junior doctor strike, and Leanne has pulled the short straw of doing nights. So I'm alone, but I am joined by my good friend and BTOG champion, Shobit Baijal, who is a medical oncologist in Birmingham and has a huge experience in lung cancer. And we're going to be talking about EGFR mutated lung cancers today. Now, the eagle-eyed or indeed eared among you might remember we've already done EGFR mutated lung cancers because I did a podcast back at the beginning in November 2021 with Samreen Ahmed, and we talked about EGFR mutated lung cancers, how you diagnose them, and we went around quite a few aspects. But things have changed, and things have changed enormously, and I think it's a really good time to revisit EGFR mutated lung cancer, what has appeared in the past 18 months, and lots of stuff has appeared, and Shobit's a real expert on that, but also what might be coming, what's new, what might we look forward to. So that's the premise behind it. If you want to go back and listen to the original podcast, I strongly recommend you do. Should still be what is still available on wherever you download your podcasts from. So Shobit, welcome to the BTOG podcast.
Thank you, Tom, and looking forward to this.
Excellent. I know you are. I sent you a list of questions, and I know you're delighted to receive those about 2 hours ago, having done a full shift as a FY1 on the ward. But, you know, these things are here to test us. So the first thing we're going to talk about is adjuvant EGFR TKIs, in particular, adjuvant osimertinib. Now, in the podcast we did 18 months ago, we talked about the ADAURA study. The ADAURA study, for those of you who may not be familiar, is a study in patients who've had surgery for early stage lung cancer. They may or may not have had chemotherapy, depending on the wish of the investigator, and they either got 3 years of adjuvant osimertinib or they got a placebo. And we knew at that point that there was a disease-free survival benefit. We didn't know much else. So, Shobit, what's happened? We've had a couple of updates on disease-free survival data, and then we've also had a really, really interesting press release about a week ago. Can you tell us about those two things?
Yeah, I mean, I think ADAURA was a real game changer in that adjuvant setting where we really hadn't seen any momentum for probably decades, and it was really the first time we saw personalised oncology enter the early stage. And the initial readout, obviously the trial read out read out earlier than the planned analysis because of such positive data, and we saw DFS in the stage 2 to 3A resected tumours of around, I think it was 0.17, and the overall population, including the 1Bs, it was at 0.2. So hazard ratios, I think I'd never seen before. So,
and yeah, just to let people know that that's an extraordinary number. So hazard ratio of 0.27 is almost an 80% reduction in the risk of disease relapse. I mean, that's huge in the overall population.
Yeah, phenomenal data. And then recently we had a 4-year update on the DFS, a slight narrowing, or should I say narrowing in terms of the benefit for the osimertinib group. But yeah. I'd say from my perspective, not a huge difference, but I think enough to put the skeptics questioning whether this was the DFS really going to translate into an OS benefit, or were we just delaying metastatic disease, the occurrence of metastatic disease. But I think really, and I think that's what you're alluding to, is that there has been a press release just very recently from the trial, or the AstraZeneca, stating that there is actually a statistically significant overall survival benefit in the study for the osimertinib treated group. So more data will come at one of the major congresses. But yeah,
and I mean that's really hit the headlines. I mean, Twitter. Well, the Twitter people I follow, it's all gone mad again, because there was this argument between the DFS believers who would say, look, you got a disease-free survival benefit, it's massive, that's all you need. And those who would say, perhaps the more purist, well, unless I've got an overall survival benefit, why are we giving it? We're just delaying it. And I think the DFS believers have been proven right, if you can put it that way. Are you convinced now? Is this now, because this is NICE approved, is this going to be a routine part of your practice for your post-operative EGFR mutation positive patients?
Yeah, I mean, I personally, I was one of the believers in the DFS, and I think it's reassuring to get this OS confirmation. That the magnitude of the benefit. I mean, I think worst case, even if we were delaying the inevitable, I think from a patient's perspective, that I think would still be desirable, a pathway to go down. And also there were other aspects of, less CNS recurrence, or etc., which would clearly, from a patient's perspective, I think would be highly desirable. But yes, this was, incorporated into our pathway. Importantly, I think, the testing for the EGFR in early stage had to be incorporated. But yeah, I was already a believer, and I think this just rubber stamps things.
And just remind us that the stages of the patients, as in the pathological stages that were recruited to the study, it was 1B
to 3A, but bearing in mind that was on version 7 of staging. So
and the benefit in 1B was a little bit less, but was still there. A greater benefit, I think it's fair to say, in the stage 2 to 3A, that the more advanced, I guess unsurprisingly, the greater the benefit. Is that correct?
Yeah. And like you said, I think that we would expect, because of just the worse or the higher risk of relapse for those patients.
Yeah. What else is going on in the adjuvant and neoadjuvant? So what about really early stage disease, stage 1A1, 1A2? There is a trial going on there, I believe. These are the small tumors. They're all going to be lymph node negative. Do you think, I think that's ADAURA 2. Do you think that's a runner? Are we going to be over treating people? What's your view on that one? And also, which you reminded me before the podcast, there's also neoadjuvant TKIs. What's going on there?
Yeah, I mean, I think it's a really good question. I mean, we are running ADAURA 2, which is looking at these very small or these very early tumors. I think it's a difficult one to know how much benefit we're going to give these patients. It still is committing them to 3 years of treatment. I must say, recruitment from our site, we have identified patients, but patients don't seem to be as inclined to jump onto this as I think they would have been with ADAURA. And I think that is driven by the fact that these are potentially better prognostic tumors, regardless of whether, these are not patients we would automatically or routinely be offering adjuvant treatment to, regardless of biomarker status. So I think this will take a lot longer to read out, or to recruit and then read out. But at the same time, it's a chemo-free treatment. So I think we need to bear that in mind. And if there is a benefit, I think hopefully the world will evolve so that we are starting to use more sophisticated biomarkers, minimal residual disease and things like that can actually help guide us to who we should be treating. And I think that would be more important for these very early stage patients, where you're right, we could potentially end up over treating a large proportion of patients with not just a toxicity potential burden, but also a financial burden of treatment.
Yeah. No, I absolutely agree with that one. What's your experience? I mean, like me, you've been using some adjuvant osimertinib for the past about a year. It's been available through NICE. I found compliance less good. I found it's more difficult. I found, very understandably, the patients are less willing to tolerate toxicities when you're giving something in an adjuvant setting, and they've felt well throughout, and now you feel more unwell because of the tablet, than in people in the metastatic setting where they felt awful before they started the drug, and it's had this amazing response. Have you found the same? And do you think we're going to have problems, as you say, with the very early stage disease keeping people on treatment?
Yeah, I think it's a great point, and I think I agree with what your perception is. I think the patient's perspective is they've probably got more to lose now. I think in the metastatic setting they are so on it, counting their tablets, they're the ones ringing. Look, I've only got a week left. When's my next supply coming? I find we're almost chasing the adjuvant patients to make sure that they're staying on treatment. And I think, the tox side, I agree. But I must say, I think my mindset has changed as well on the tox side for the adjuvant patients. And not that I'm, should I say, relaxed about metastatic patients getting tox, but I think, again, they will put up with more, and I would kind of expose them to more because of the benefit. We're improving, we're trying to get them to live that those extra years. Whereas in this setting, as you said, with the risk that we could be potentially overtreating, but also that these patients are going to live hopefully for another 30, 40, 50 years to, things like the cardiac side and cardiac toxicities and stuff. I don't want to leave somebody with long-term heart failure.
Oh, that's a really good point. Yeah,
a
absolutely.
lot more vigilant with that side, where I must say I'm a lot more relaxed in the metastatic setting.
If you've got someone in their 40s who you might cure, you don't want to be causing permanent LV dysfunction. Absolutely. Okay, so that's adjuvant treatment. OS data, as you say, they produce these press releases, and we're told it will appear in a conference. We're guessing probably ASCO, which is a big American conference in June, or maybe AACR, which is again in the States in the spring. So that's that. We're going to now move on to exon 20 insertions. So we talked a little bit about this with Samreen. She meant a drug called TAK-788. That's now known as mobocertinib. That's the generic name for it. Exon 20 insertion mutations, for those of you who aren't familiar, are what are referred to as the uncommon EGFR mutations, and it's probably the commonest of the uncommon mutations. And we now have two drugs available, two licensed drugs, only one of them actually NICE approved at the moment. One's a tablet, mobocertinib, one's a drip, amivantamab. Amivantamab's a bispecific monoclonal antibody against MET and EGFR. Mobocertinib is a tyrosine kinase inhibitor. So you've had a bit of experience of these. Do you feel one is better than the other? If you had theoretically access to both, do you have a preference? Do we have any head-to-head data on
them? I think there's no head-to-head data. There was, I believe, something presented at ASCO where they kind of did some sort of statistical adjustments to compare the two drugs. I think there was a poster on that. And I think that the bottom line is there isn't much to call in terms of efficacy. And I think both the Exclaim and Chrysalis studies, objective responses, yes, slight difference, but we're around the 30-40 mark. I think PFS is just a bit above the 6-month mark. So I think efficacy-wise, there's really not much, in my opinion, to call between the two. I think the one thing probably stands out is that we're not, yes, it's great that we've got traction in this alteration, but we're not seeing the same kind of gains that we're seeing in sensitizing mutations, and I can't see these drugs entering first line just yet. I think
that's a really important point. So that they're not licensed first line. I should have said that. They're licensed after platinum based chemo. So people with an exon 20 insertion, folks, you should still be giving platinum based chemo. And you're right that response rate 30-40%, that's way below what we would see with osimertinib, and the duration is shorter. So is it just we haven't got the right drug, or is this a more difficult disease to treat, do you think?
I think probably the latter. I think and I think and the drugs are showing that. I think the binding, there are issues with the binding site and with the drugs, and hence what we're finding, which is something that when you're saying what do we call, the previous question about what would I call between the two drugs, I think we're seeing, with these drugs, although we are getting a bit of benefit, there is a tox trade-off with them, and I think there is a challenge, but both in terms of efficacy. Yes, we have got something, and I think it's definitely better than docetaxel, or moving on to the cytotoxic treatment. But I think there are still challenges in terms of toxicities. As I said, amivantamab, we've got to consider it's an infusion, and quite a frequent infusion. You've got to do a day 1, day 2, then weekly before you move to 2 weekly. And you've got, infusion reactions are relatively common, but tend to happen earlier on if they're going to happen. And then you've got a mix of EGFR, and because it's a MET binder as well, MET-based toxicities, and mobocertinib being a carries a lot of the EGFR wild-type toxicities, and in particular diarrhea seems to be quite prevalent with it. And I think that's something that we need to bear in mind when exposing patients to it.
Yeah, no, absolutely. I think it is. The way I've read it is I thought the mobocertinib probably, as you say, more diarrhea, the amivantamab, the infusion reactions, and certainly more of a pressure on our chemotherapy units. And I agree, not much to choose between them efficacy-wise. That first-line treatment, would you be giving these patients pembrolizumab, pemetrexed, and carboplatin, or would you just be giving them pemetrexed and carboplatin? And what's your rationale, assuming you know, of course, at that point what their mutation status is with the exon 20 insertion?
So if I know at diagnosis, I think one easy aspect is that potentially we can't give the pembro carbo pemetrexed because our BlueTech form stipulates that the patient has to be EGFR wild type. So I guess
although I would say, in the interests of geographical equality, that applies to England only with the BlueTech form. But you're absolutely right. If you are subject to a BlueTech form, you should not be giving that. And what do you think the principle behind that is?
Sorry, you can repeat that, Tom?
Well, what do you reckon the concern about giving the immunotherapy is? Why are we being restricted from that?
I mean, I think first of all, there's definitely I think that there's a lot of data, at least single agent IO, we know we have very minimal traction with EGFR patients, these driver mutation patients, these never smokers, and that's regardless of PD-L1 expression.
Yeah.
And there are reasonable data sets, again, to show that even the chemo combination with IO potentially is not adding much benefit. And I know it's looking at the flip side or the tail end of treatment, but we've also had recently readouts for patients who progressed on their EGFR TKIs, where we've looked at platinum chemo versus platinum chemo and pembrolizumab, immunotherapy, and a couple of trials have shown negative benefit for using immunotherapy in combination. So I think that there's the question about actually any efficacy from it, but also a potential concern, which has been shown, especially using single agent immunotherapy, that if in these EGFR patients, if we then expose them to a TKI after IO-based therapy, we can lead to some issues with adverse events, delayed immunotherapy-based adverse events. So again, a potential toxicity issue as well.
Yeah, absolutely. And I'm wary of that. And I think even if I had access to chemo immuno first line for exon 20s, I would not be throwing that around. I'm not sure that's a great way of doing it. So that's the commonest of the uncommon mutations, but we do have other uncommon mutations. And one thing that caught my eye, and I'm sure caught your eye too, which sort of came out actually just after we did our last podcast, was a paper looking at rare uncommon mutations and the fact that actually you can predict response to TKIs and which TKI based on this. And the paper, the lead author is someone called Jacqueline Robichaud, Robichaux, for those of you who want to read it up. And I really would recommend you do. I think it's fantastic. And it was published in Nature in September 2021. And what they find is that you can predict response. Well, first of all, you have an atypical mutation. You do less well. So atypical is everything other than exon 19 deletion and L858R. The overall prognosis, unfortunately, in patients with an atypical mutation is less good. They then talk about how you can predict response based on the structure of the mutation. They talk about exon 20 insertions, as we've talked about. They talk about the different types of exon 20 insertions. But they then talk about various other aspects. But one particularly caught my eye is something called PACC mutations, PACC mutations. And these are ones which are characterized by, for example, G719X mutations, which people might have spotted. You may have also come across an L747X mutation. The other one, for example, S768I. Those are probably the three most recognizable, but there are others. And these ones are much more sensitive to afatinib than osimertinib. And I think we've often known that perhaps a little bit more anecdotally, and this is the evidence behind it. Shobit, for your non-classic mutations, your non-exon 20 and your non-L858Rs, are you still using afatinib, or do you think we should be just throwing osimertinib at everyone and don't worry too much about the mutation type?
No, I think that paper that you mentioned, it's a very I think it's interesting in the aspect of actually looking at this in a different way, and I think the reason it's really poignant in the rare mutations is because, and I think you know what you said it exactly alludes to that, is that there is a lot of conflicting data out there. There's a lot of heterogeneity between the alterations. There's a lot of in terms of data, there's a lot of data, a lot of small series, a lot of retrospective data looking at what is the right treatment for these patients. I mean, for me, really driven by the large publication that was in, I think, a couple of years ago in Journal of Thoracic Oncology, looking at afatinib. I think it looked at about 700 patients with rare mutations. And a lot of those came from the Lux Lung studies. And you know, the response rates were pretty close to what we see with the more common mutations. So driven by that, for me, I think there definitely is something in afatinib, and I think the paper looking at protein structure, you know, I think that's a really unique way of looking at things, and it'd be a great way, you know, in a utopia world where we could actually do that and actually choose our drugs based on the actual protein structure, because you know, it definitely does matter. If the mutation is away from the binding site, it probably doesn't matter what drug you use. But if it is then more affecting the binding site, then clearly the drug choice is very important in that aspect.
Yeah, absolutely. I think the real key is when you get your molecular biology results back, read it properly, make sure when it says EGFR mutation, you know which one it is. If in doubt, speak to your friendly local lab. We have an outstanding service from Mars. So I had a patient recently who had a very rare EGFR mutation. I went through the paper, the Robichaud paper I mentioned is actually in that as a rare variant that would or should respond to afatinib. I've chosen afatinib and she's responded very well. So I'd absolutely agree with you, which is make sure you know what you're treating. And it may well be that afatinib's a better drug for select patients, albeit a more difficult drug for patients to take, unfortunately.
Yeah, and I think the other aspect is even exon 20 insertions. There's a small proportion of the proximal alterations which can be very sensitive to first gen drugs. So
yeah,
like you said, it's really worth not just knowing the mutation, but knowing which exon, and even actually getting to the granular level of the alteration, because it really can drive the drug of choice.
And actually that reminds me of something you mentioned at the beginning, that some of us are still using PCR-based assays, COBAS, for example, PCR-based assay for EGFR, that misses, we know, the rarer mutations. And so ideally we should all be having access to next generation sequencing. And if you are using a PCR based assay, you have a patient who's never smoked, nothing else has come up, no mutations, I would strongly advise trying to find a way of having perhaps a different way of looking at the DNA, RNA to understand whether there are maybe some mutations in the DNA that have been missed through PCR. So we're going to jump on to advances in metastatic first-line disease. So when we were talking with Samreen, we kind of reflected on the fact that really, with the exception of those rare mutations, when we're thinking about common EGFR mutations, osimertinib is very much what we do. Pretty much, we all give it. It's a single-agent drug. What's new? I get asked a lot about, can I have chemo and my TKI together? We know from a study came out about 2021, but I think we had an overall survival update that adding chemo to gefitinib is helpful. What's the data there? Is that enough to make you start using a gefitinib chemo combination? And if not, because gefitinib's an old drug, are you throwing around osimertinib and chemo, or are there trials you're waiting for before you make such steps?
Yeah, I mean, I think there was a lot of excitement. I think that was during that presentation, I think there were a couple of strategies that were talked about that might boost what we're already achieving in that first line setting. And you're right, well, the first one was the gefitinib combination with carboplatin and pemetrexed. I think the PFS probably, I think it was shy of what Aussie achieved. I think it was around the 16-month mark for the combination. And yeah, I think there was a lot of interest generated in that. And on the back of that, we have got FLAURA2, which has close to recruitment. And I think we obviously await the results of that. I'd be interested. I think we have to see a significant gain over osimertinib, because obviously there is a tox burden, there is a infusional burden. I think we all get excited when we see an EGFR patient. We reach for our prescription, expect a tablet, to get the tablets ready, and the patient goes home and they live, they don't visit the chemo unit. We see them in clinic every so often, and it's a very easy ride for the patients. And a lot of patients that you speak to are quite frightened, especially the ones who are used to being on oral TKIs, are quite frightened about the concept of chemotherapy. So I think there needs to be a significant gain to what we've achieved with FLAURA to make that practice changing.
I agree completely, and I think, I think being the new diagnosis of an EGFR mutated lung cancer is usually so shocking. I mean, anyone diagnosed with lung cancer is shocking, but I think when you've never smoked, which probably these patients have never smoked, the one very small glimmer is, well, here's a tablet, and it isn't chemo, and you don't have to come in for chemo. And I agree that I think you need to have quite a big benefit for that to be overridden. What about new TKIs? So we've talked a lot about osimertinib. It remains king. Vitamin O, we call it down my neck of the woods because it's good for everyone. It's not really good for everyone. Please don't everyone take it. But actually, we haven't really moved on from it. I mean, it's been dominant for so long. Is anything coming around the corner? Is there another osimertinib around the corner? Are there any pretenders to the throne?
I mean, there are other third generation TKIs equivalent to osimertinib. Lazertinib is one example, which is getting some traction in as a well. We're awaiting data of it as a single agent, but also talking about other first line strategies as part of the Mariposa study. There's the combination of lazertinib with the drug that you talked about earlier on, amivantamab, combining the EGFR MET bispecific with the EGFR TKI. And I think an interesting strategy. I think MET inhibition up front failed when we looked at it using METMAB.
Yeah, that was a huge disappointment. That was we were all convinced we'd cured lung cancer, and it was the catastrophically negative study for a number of reasons.
But I think amivantamab, it's got a different mode of action. It's got a broader mode of action. It's got this immune recruiting aspect to it as well. So I think that's going to be an interesting strategy and one I think to look out for.
Yeah, I think so. And that there are other agents coming through, a number of different ones. Aumolertinib is one which is an interesting approach, mainly because the approach with that drug is more trying to show similarity, perhaps in activity, but more focusing on an affordability of drug. And I think making sure agents we use for EGFR mutated lung cancer are as affordable and as accessible for everyone, including in countries with perhaps less well-resourced healthcare systems, is really, really important. Okay, so we wait for chemo TKIs with FLAURA2. We wait for Mariposa to see whether lazertinib might be better, or lazertinib and amivantamab might be better, and we have a number of other drugs coming through. But still, we are largely dishing out osimertinib. So in the last few minutes, what's the post-osimertinib landscape like? I was actually going through a couple of slides last week, and I came across a talk I did in something like 2018, I think it was. And I put a slide up from 2017 in that, where someone is talking about resistance mechanisms to osimertinib, and here are all the resistance mechanisms, and we're going to target MET, and we're going to use this drug, and we're going to get new mutations, we're going to have that drug, and we're going to have a whole different landscape post osimertinib. That actually hasn't happened. In reality, the average, I don't want to use that word, but the average patient you and I would see with osimertinib who has progressed outside of clinical trials, we are reaching for platinum-based chemo. Being a bit more optimistic, what has caught your eye? And if I could prompt you, there was some data that came out at ESMO in Paris in 2022 in the autumn with looking at patients with MET amplification. What's all that about, and what do you reckon?
I mean, yeah, I think the post-Aussie space is really exciting, and I agree. I think we've known about the alterations, but we've not been able to action them as quickly as we would have wanted to. And I mean, yeah, if we start with MET amp, I think first of all, MET amplification is one of the more prevalent resistance mechanisms. So definitely one where a targetable option is highly desirable. And I think, well, the data that comes from the Insight 2 study looking at tepotinib, a MET TKI, combined with osimertinib. I think the first lesson that we've learned, and I think that probably is why we've struggled to get traction for so long, is that actually understanding that we need to keep the EGFR TKI pressure on in that resistance setting.
Yeah.
And we've definitely learned that from the MET space, both with Insight 2. So this is looking at tepotinib combined with osimertinib, and I think response rates were around 50%. So quite
Which
impressive.
I was quite impressed by. And there's two drugs which are available. I mean, tepotinib is already available for MET exon 14 skipping mutations, and osimertinib is available now. We should stress that that's outside the licensed indication of tepotinib, but it is interesting. There was no survival data, if I remember correctly, but that response rate, I think, is respectable, as they say.
Yeah, and a similar strategy using one of the classes of drugs that I'm getting most excited about, antibody drug conjugates. So a drug called Telezo-V, which is a MET targeting ADC, and a very similar strategy in the Luminosity study, using it as a single agent in the EGFR progressing patients. There was very little signal, but there's now a phase 1 study combining it with osimertinib, and again, response rates hitting around 50-60%. So there definitely seems to be something in keeping that EGFR pressure on.
Absolutely.
I think MET's a really exciting space, and hopefully we will have reimbursed treatment options in that setting. And I think clearly, obviously, our testing landscape has to also evolve. We need to be testing for these alterations.
And that would, of course, require us to re-biopsy at progression, which we always used to do when we were using Aussie as a second-line treatment. So maybe we need to go back to that. C797S, so that's a mutation which we see a de novo mutation, resistance mutation. I remember talking about it for a long time now. I very rarely see it. I don't know if it's just my patient cohort. If I do see one, have you got anything up your sleeve to target C797S? Well, not you personally,
no,
but does anyone?
There is a lot of interest. I think there's an array of 4th gen now EGFR TKIs. Blue 945 is one of them, which is, I think, is it the Symphony study, which is the early phase trial looking at this drug. So I think yes, there is, and there's a lot of work going on in that. But at the same time, there are a couple of other strategies coming through which seem to be pan-resistance mechanism targeting, or should I say non-target, or in terms of efficacy against pan alterations. So there's a HER3 antibody drug conjugate in the Athena studies, Athena trial looking, I think the response rates, the patients had progressed on the EGFR TKIs and chemotherapy. And what we know is that HER3 tends to be overexpressed in EGFR patients on progression. I think about 80% are overexpressing HER3, so it makes it quite an attractive target for an antibody drug conjugate. And I think response rates in the post-TKI and chemo setting was around 30%. And interestingly, we saw responses regardless of the alteration from MET to C797S to no targetable option. I think that's really emphasizes the mode of action of antibody drug conjugates. The alteration it's targeting doesn't have to be driving the cancer cell, but becomes a useful target to deliver the payload. And I think
I absolutely agree. I think a really interesting drug. I'm very impressed you got so far without actually naming the drug itself, because it's very difficult to pronounce. So off you go.
Dirk's teacup.
Very
With
good.
a deep breath.
So I think absolutely. I think that's a really interesting approach, and I think the idea of not having to necessarily target your resistance, but something else that's now a susceptibility is really good. We've talked about Mariposa, which was the first line trial of amivantamab, bispecific monoclonal, and lazertinib. But Mariposa 2, as the name suggests, is a second line study after osimertinib. I find it quite difficult to remember the details, but this is chemo versus chemo plus lazertinib in various combinations. Is that right?
Yeah, exactly. And I think, again, an interesting strategy, partly because, as we've already mentioned, MET is a prevalent escape mechanism. But again, the premise of this is to target all alterations. And I think there was a cohort within the Chrysalis study that where responses are small numbers but pretty impressive responses. So I think this again is an attractive strategy, and I think one to look out for. Again, we've got to bear in mind it is. I think the toxicities will be interesting. Obviously, we've got a 4-drug regimen here, so that's probably one thing that we need to bear in mind. But again, I just emphasises the amount of activity happening in the post-Aussie space.
Absolutely. And the last one to mention in the post-Aussie space is Keynote 789. It's a study I was involved with. This was, I'll just briefly mention it. This was pemetrexed carbo versus pembrolizumab pemetrexed carbo after first-line TKIs. That's a negative study. So the message from that, folks, is that if you have a patient who has progressed with an EGFR mutation, who has progressed on osimertinib or their TKIs, don't give them pem carbo, because that's not evidence-based. Pemetrexed carboplatin alone is there. If you have someone who's very keen to have immunotherapy, then Shobit, there's still access to Empower 150, carbo, Taxol, Bev, and Atezo. Are you an Empower 150 fan? Do you use it very much, or more for the select cases?
I'd say select cases. I don't go all guns blazing for everybody. I think it's a tough regime, both logistically and tox based. But definitely, the Empower 150 data it's the first data we've got in that setting showing actually benefit for an IO based strategy. And I think one thing that's great, and we don't like negative studies, but I think the Keynote 789, it's an important one to know, because I think sometimes there's this mindset that more is better. And to know that we don't need to reach out for the IO in that setting is important. So yeah, potentially it is clearly the VEGF drug in that quadruplet that's driving the benefit. So, but no, it's not one I put all patients on.
I agree. I think it has its role, but the more updated overall survival benefit, the more updated overall survival data has shown that benefit is lost over time. So I think it has a role in some patients, but it's not something we use hugely, although it is, again, NICE approved and is available for your use if you need it. Finally, last topic before we wrap up is patients with locally advanced disease. Now, there's a huge amount of press releases, data coming out on neoadjuvant chemoimmunotherapies, separate podcast for that, obviously. Question we're often asked is, in that neoadjuvant setting or in the chemoimmunotherapy setting, chemoradiotherapy setting, so imagine the Pacific kind of scenario, what should we do with patients with EGFR mutations? Would you be giving someone adjuvant osimertinib after their chemo rad, or do you think we should be giving them adjuvant immunotherapy with durvalumab, or are you waiting for trials to tell us what to do?
Definitely the latter of those options. I think, and on that note, there is the LAURA clinical trial.
There is LAURA to add to FLAURA and FLAURA2 and ADAURA and ADAURA 2, and there's someone's doing well in the naming of trials there. So FLAURA, this is LAURA. So LAURA is for locally advanced disease, presumably.
Stage 3. It had chemo rad and then adjuvant Aussie, and I think without that, I'd feel uncomfortable outside of a trial giving an EGFR mutated patient adjuvant Aussie post local therapy. And no, and again, Derva, for the reasons we've already alluded to, I would avoid giving these patients. My personal practice would be not to offer adjuvant durvalumab, even if they are PD-L1 positive. I think for the reasons, one, I'm not sure that they'll actually get any benefit, but also I'd be worried about if they did relapse, would I run into toxicity issues when I do need to start them on the TKI.
I absolutely agree with you, and I think, again, you need to know that mutation status according to most of the reimbursement forms in the UK, and I think in EGFR, I think that adjuvant immunotherapy is probably without evidence base. Shobit, thank you so much for giving up your Tuesday evening on strike night before your long day on the wards tomorrow, taking blood and other such things. So that's incredibly helpful. I hope that has cleared up various things about EGFR mutated lung cancer. To remind people that BTOG 2023 is but a month away, a little bit more. So if you haven't signed up, then there's clearly something wrong, because you should have signed up. And if you do sign up, not only will it be a fantastic experience, multidisciplinary working, huge amounts of education networking, but also, if you're lucky, you might see Shobit in the hall, and what greater reward could there be for that? And we look forward to you joining us for our next podcast. Thank you very much. Thank you for listening. We hope you enjoyed this podcast. For more information on BTOG, including educational events and how to join, of course, you can visit www.btog.org. Just to remind you, we would love to hear your comments, thoughts, questions about things we discussed, and for the really interesting ones, we'll even discuss them in our next podcast. You can contact us on info@btog.org or on Twitter @btog.org. Thank you very much.